and Health Association for collaborating with Ceylon Chamber of Commerce to organize this informative session here today. And on behalf of the Chamber, I wish to also thank our sponsor, Astrin Limited, for helping us take this forward, this initiative forward to you. Thank you very much. And before we begin, let me kindly request all participants to please adhere to our house rules. Kindly ensure that your cameras are switched off and your microphones are muted unless you are a speaker in this session. And you may also use the chat option available to you to raise any questions to which we will pick it up during the Q&A session. Just in case we do not answer any of your questions, you're most free to send in your questions through email to which we will individually respond to you. Thank you very much. And let me now hand over the session to Dr. Aseni to take over. Thank you very much.
Thank you, Amanda. Hello and welcome everybody to this session. As Amanda said, please send all your questions via chat box, and we are actually, there's a lot of time constraints, so we may not be able to answer all your questions. So the responses to unanswered questions will be collated and sent to all participants after the event, along with the recorded version of this webinar. And let me take this opportunity to thank all the speakers. They're all busy people, doing big jobs, and, for agreeing to share their valuable knowledge and experience to help us keep our employees healthy and safe with minimal disruption to business continuity. And I also need to take this opportunity to thank Nick Paul, the CEO of Society of Occupational Medicine in UK, who has assisted in organizing this event, because Society of Occupational Medicine does some marvelous work on improving employee health and well-being in the UK. And they have supported us whenever we have requested some support. They have always supported us. So thank you, Society of Occupational Medicine. So if I can let you know the lineup for today's session. First is Dr. Susie Pereira, who is the Deputy Director General at the Ministry of Health. And she will talk about the challenges faced by the employers from an official perspective. Then comes Professor Anne Harris, President of the Society of Occupational Medicine UK. She will talk about the how to support employees on physical and mental health. Then Professor Ewan MacDonald, who's the head of the Healthy Working Lives Group from University of Glasgow. He will enlighten us on the long-term health effects of COVID, which can impact the employees and the workplaces. Then comes Dr. Changa Kulkuratna, who is a consultant in infectious disease and has vast experience in Singapore and USA. He will talk about the much talked about vaccination and building of immunity. Ms. Louise Burt, who is a industrial hygiene, head of the industrial hygiene from GSK in Asia and Pacific region. She will talk about the risk mitigation methods. Most importantly, the airborne control methods. And finally, Mr. Artha Salgado, Associate Director of EHS and Risk Management at Ansell, who's responsible for Asia and Pacific region. He will talk about all the hands-on experience, all the challenges they have faced in keeping their employees healthy and safe. So first, let me invite the first speaker, Dr. Susie Pereira, to initiate the session. Let me just give a brief background on Dr. Susie Pereira. She's a consultant community physician, currently the Deputy Director General Public Health Services at Ministry of Health. She has a long track record of serving in the Ministry of Health in positions of Director Policy Analysis and Development, Director Organization Development, and as Acting Deputy Director General Planning and Acting Deputy Director General Public Health Services overseeing communicable diseases. She has made significant contribution to the health system development. In the COVID-19 response, she played a lead role to develop guidelines for public activities and work settings. It's all yours, Dr. Susie.
A good day to all of you. It's a pleasure to be here talking to all of you. And I will just share a few slides which will support my opening remarks. So briefly, I would like to just point out that we are in a protracted phase of what we call a level 3 transmission. I will explain that. And also the importance of control measures that we are taking. And in specifically the industry needs to identify through being proactive uh, to identify all the possibilities for spread and to take measures to prevent, as some of these are very industry specific. Lastly, I would touch upon briefly on the vaccination program that has commenced in Sri Lanka and some of the challenges. So this would be to control the workplace spread, from work to home spread, and spread from home back to work. So in the levels of transmission that we have declared, we are in level 3, level 4 being the full-blown community spread. And we have a situation right now where we experience multiple clusters. But we have been fairly, I would say, fairly good in containing these clusters and preventing further spread, and that is why we are not declaring a level 4, which is a community transmission. So permitted functions are declared according to the levels, the alert levels, and level 3 functions have been informed to the public. This is also a challenge because it is always that we find that these permitted functions are practiced exactly the way we have suggested. Now, the importance of control measures. So I mentioned that it is in the form of guidelines issued for public activities and work settings. So these are subjected to supervision by health authorities, and workplaces are expected to adopt the guidelines and give assurance to local health and administrative authorities on compliance. So this is done fairly early, as far back in May. The need for workplaces and certain public um, enterprises, as we would say, to declare and give assurance that they are adopting the control measures. But more specifically, there are prevention measures that we have uh, adopted and declared, that is the need for health and safety officer in the workplace settings, and for creating awareness among the employees, and of course taking ownership. And this is not only the employer but self responsibility, because in a protracted phase of the epidemic, we think that behavior change, the self responsibility becomes very there are various measures of surveillance which we have prescribed in the form of temperature monitoring uh, and random PCR tests. Now, in the case of reporting these cases, isolation and testing of contacts is what is uh, I would like to mention the importance that of proactive identify all possibilities for spread and take measures to prevent. So this is when we say the health and safety officer, there is a big role for for the health and safety officer, because the work setting must be carefully analyzed and understood, the nitty-gritties. I will just give a very short, very brief example of something that happened uh, late last year when there was a massive spread in one of the industrial establishments, and it took even the health authorities, it took some time to really understand the dynamics of this spread uh, within the industry. Uh, and two main considerations, two main factors were identified. One was the the place of their the accommodation facilities and how they share accommodation, and several people moving from one industry to another industry shared contract workforce. And of course, within the industry, the fact that there are some categories of staff who would be meeting some of the employees more often than the other.
Dr. Susie, you're muted. Dr.
Can you
Susie,
hear
you're
me now?
muted.
Can you hear me now?
Yes, yes.
Yeah, I don't know which part you didn't hear, but what I'm trying to say is that each industry has their peculiarities, and this is why a health and safety officer needs to understand the dynamics. And even the health ministry took some time in understanding what led to a huge spread last year. Right? So, being proactive to take preventive measures is very important, and this differs from industry to industry. This has got stuck. No, it's okay. I think, yeah. So finally, I just want to mention about uh, the vaccination program and challenges. Well, we all know that we are waiting for the vaccine. Everyone is eager for the vaccine, but there is a prioritization that needs to be followed. Simple fact is, because the supply is limited, the global supply is limited, and therefore the local supply is limited. We do not have vaccines for everyone, but the government is committed to get it for everyone, and this is going to come into the country in small tranches, right? So we are not getting the full quantity at the speed we want, but that doesn't mean that people are going to be excluded, right? So the most affected with the disease currently are the elderly, but it has not overwhelmed the health system at the moment. But we recognize that the elderly and those with non-communicable diseases, it is very important that they be vaccinated to prevent deaths, and the health system's burden will therefore reduce. But the government is also committed to give the working population, and for which the special procurements for this is being done through the government. So we have the COVAX facility, which is giving us 20% of the population to be vaccinated, which is 4.2 million. But above and beyond that, the government is procuring for a population of nearly 60 to 65%, which is really the eligible population. And but the everyone must really understand, especially the industry, because we have been given a lot of we are being urged that the industry should be given this, especially before the new year time, and that is when most of the employees would go to their respective residential places, go back home in crossing district boundaries, and we are being urged by employers to quickly vaccinate the workforce. So there is a false sense of security with vaccination here because um, this vaccine is really not going to totally prevent the transmission. So that I think there will be speakers after this who are going to speak on this. It will be interesting to listen. This false sense of security that the vaccination will entirely prevent the spread is something that needs to be dispelled. And full protection is also not possible with just one dose. And the younger people who will be getting it, if this decision is taken to immediately vaccinate the workforce, there is a responsibility still because there is not going to be immediate protection to block transmission. They still have the responsibility to protect the older people, even if they get the vaccine first before their parents and so forth. So this is some message that we have to give to the Sri Lankan workforce because the government is committed to give the vaccines to the industrial sector also. But the timing of this, we do not know whether everyone will get it before April or how this is going to happen. But it is a challenge certainly for us. Thank you. I think I would like to thank the organizers, the Chamber of Commerce. I would like to thank Hosseini for inviting me to make these uh, remarks. Thank you very much.
Thank you very much, Dr. Pereira, for sharing your experience and providing some guidance because we are all waiting for everybody's, in a dilemma these days. And I think you touched up on, the basics of what we need to take because some of us, we all need to take the responsibility. Some of us think that it's only the government who's responsible, but we all need to take responsibility at this stage. Thank you very much. So next up is Professor Anne Harris. She will talk about the importance of mental and physical health at this stage, during the pandemic. Professor Anne Harris has a significant experience in occupational health education, latterly as the course director for occupational health nursing and workplace health management programs at the London South Bank University. She is the president of the Society of Occupational Medicine. She is also a fellow of the Royal College of Nursing, honorary fellow of the Faculty of Occupational Medicine, and both a principal fellow and a national teaching fellow of the higher education. She has contributed to the development of occupational health initiatives both nationally and internationally, and has a particular interest in promoting mental health in the workplace. The screen is all yours, Anne. Thank you.
Thank you. Can you hear me? I'm assuming so.
Loud and clear. Yes.
Lovely, thank you. I can't share my screen. Can you play my presentation if I can't get in with my slides?
And I will share the slides and you can do the talking and I'll just share the slides.
And I'll just say next slide. Thank you, Seni.
Yes. Okay.
Thank you very much for asking me to speak. It's an absolute honour to support you. It's a good thing I've sent a backup slide deck, isn't it, Hosseini? What I'm going to be talking...
Oh, sorry.
Thank you.
Sorry.
No, that's Louise's.
Yes. Sorry.
I can start talking. I'm going to be talking about supporting the physical and mental health of the workforce and workforces during the COVID pandemic. I understand most people here are not from a medical background, but there will be some medical people here. So, next slide, please. So the starting point is all about risk assessing and then managing those risks. So that's an important starting point. Next slide, please. Okay, so I'm plagiarizing here, but at least I'm giving credit to Ewan MacDonald, who's going to be following me in these presentations. Risk assessing for COVID is all about advising workers and their organisations about competence in risk assessment and control. Next slide, please. Okay, so the process of hazard and risk control is about identifying, assessing and evaluating the control measures and trying to eliminate the hazard. So here we are, the definition of hazard is the potential to do both physical and psychological harm. A risk is the likelihood that harm will occur under particular circumstances. So as far as we're concerned, as managers and occupational health professionals, is that risk management relates to eliminating and controlling the adverse effects of risks within an organisation. Next slide, please. We've just gone through that. Next slide. So we need to think about the people, the premises, the plant, that's the equipment, the work processes, policies and procedures. So COVID-19 hazards focus on biological hazards, that's the virus, chemical hazards, because your employees will be having to wash their hands more and to use sanitizing products, ergonomic hazards, particularly important thinking about wearing personal protective equipment. And then the element that I'm going to focus on a little bit is the psychosocial hazards. So work requirements should maintain COVID-19 safe systems of work, really important. Next slide, please. Oops. So the first step in the COVID risk and health management process is underpinned by 5 steps. So there's the virus. If we could go to the next slide, please. Is to identify the hazards and high-risk job roles and work activities. So that's up to the managers. Next slide. Then we identify who may be affected and how they might be affected. From then, evaluate the degree of risk, evaluate the efficacy of the hierarchy of controls. And I think Louise is going to talk about that in more detail later. Next slide, please. Step 4 is recording and acting on the findings. And finally, review as knowledge and or circumstances changes. So once there's an effective vaccine, that's a real help. Can you just hold it at that? No, go back. So elements which increase the risk. Okay, next slide. Elements which increase the risk of contracting COVID. Overcrowding, including homes, transportation, and there's already been a comment in the meeting chat about that, and workplaces. Then the type of work that people are carrying out. So people working in healthcare facilities are at increased risk compared to people working in office spaces where people can there be ensure social distancing and they're not as likely to come into contact with the virus as those looking after COVID positive patients. Workplaces where social distancing or effective ventilation is difficult to achieve. Work undertaken outdoors may be more COVID-19 safe compared to some indoor working. So some areas such as tea picking, for example, there are people there are working outside. You need to think about the vulnerability of people should they contract COVID-19 as it varies. I've put a link there which will be of particular interest to medical and nursing colleagues, but it's still useful for others to have a look at the vulnerability dependent on issues such as ethnicity and age and pre-existing health problems. From that, we can think about various categories for people in relation to getting COVID. So one group is extremely vulnerable, and that's people who are recovering from cancer treatment, so treatment with radiotherapy or chemotherapy, people with severe asthma, others who've got poor immunity. So, for example, if an individual's had a car accident and had their spleen removed because of an injury to their spleen, they are at particularly high risk, because the spleen is part of the protection of the individual in relation to infections. Then there are those who are highly vulnerable. So people who are otherwise well, but with long-term illnesses such as diabetes. Then the lower risk are those who've got increased vulnerability. Could you go back a slide? Increased vulnerability compared to young, well people. So people at increased risk are those aged over 70, so you may well have some workers in that category, or younger people, but they've got health issues such as mild, well-controlled asthma. Next slide, please. So just to recap, those at highest risk are over 70. Then decreasing is under 70, but with underlying health conditions. Those who are significantly overweight, people with long-term conditions affecting the lungs, heart, liver, spleen, those with poor levels of immunity, and those being treated for cancer. Next slide, please. So let's think about what advice I would give as an occupational health practitioner to managers and workers. So thinking about managers, of which many of you are those people, I'd be talking about how to control exposure, because you want to reduce the anxiety of your workers thinking about, I might get COVID at work and take it back to my family. Protecting people at particular risk. Supporting people to be able to be in the workplace following a COVID-19 absence. Recognising reduced well-being. Going back to supporting people returning to work, Professor McDonald is going to be talking about long COVID, and COVID has long-term effects. So an individual who's had COVID may well find when they're trying to return to work that they're increasingly tired, that they're also complaining of joint pains, and they feel very unwell in the first instance. So thinking about coming back to work may well be a major leap for them. The advice I'd be giving to specific workers following a COVID-19 is developing return to work recovery strategies, considering the physical and mental health of those people and being really aware of the effects of that post-viral tiredness. Psychological support can't be underestimated, because the worker will have certain thoughts in their head about, first of all, their own illnesses, and they may well have experienced the illness of other people, such as family and co-workers. Many of those may have died, and they will be going through the process of bereavement, having experienced that. Next slide, please. So let's think about mental health, because that is something that isn't easy to see. You can see when somebody has got pains or if they're having difficulty breathing, but you don't necessarily see the mental health effects. So having spoken to people working in our hospital services, there have been reports of employees being very fearful of going back to work. And that will be the same, whether it's a healthcare facility or a factory or an office environment. They report symptoms suggestive of post-traumatic stress disorder. That's where the person who's suffering from it has repeated flashbacks going back to the time that they're ill. And that's particularly important for those who've been severely ill, perhaps in intensive care, where they've seen people around them dying, and for healthcare staff. Those healthcare staff are working at twice, 3, 4 times the speed that they were working in the past, and also a larger number of people who are dying. And they could be looking after several patients over a day that sadly die by the end of that shift. So what are the implications? Well, thinking about work or workplace anxiety, the fear of coming back to work, thinking about the effect of lockdown and curfews. In the UK, we've had lockdown. we've not had the curfews that I gather parts of Sri Lanka have experienced. If you've been stuck at home, not being able to go out in a curfew, the psychological effect of that can't be underestimated. Then there's the issue of finances. Many people will have lost their jobs. If you lose your job, you lose your income. If you lose your income, you can't easily place food on the family table. Next slide, please. So thinking about returning to work strategies for employees, large multinationals in Sri Lanka may well have access to OH advice. If you do, the referral is the same process as any other condition. Remain mindful of the effects and residual effects on the worker's physical and mental health. Think about the functional effects, both physical and psychological. Post-viral fatigue could have a significant impact, particularly people maintaining their full working capacity for a full working day. Maybe it's affecting their ability to breathe, and maybe also it's affecting their musculoskeletal system, which means moving, handling heavy equipment is difficult. So let's think about the approaches following serious illnesses. Consider COVID and the effects, plus the effects of long COVID. Early interventions are essential. Multi-professional interventions for vocational rehabilitation, where that's available, could have access to specialist occupational health nurses, medical practitioners, and physical therapists, such as physiotherapists and occupational therapists. And many of these people might need psychological support. So as a manager, if you're thinking about getting a person back to work, think of the process of de-icing, discussing the issues that an individual might have, what that employee's ideas are about returning to work, exploring their concerns and their expectations, and thinking how you can meet those concerns and expectations to make that return to work more productive. And I can't underestimate enough the effects of post-viral tiredness. If that's the case and the person is having this post-viral fatigue, is it possible to facilitate a phased return to work? Just like you wouldn't expect an athlete to participate in an Olympic sport without being able to be training up to that, the same for people with post-viral tiredness. Next slide, please. So raising awareness of the impact on mental health managers and employees. This is a new way of working. Innovative management techniques by empathetic managers is essential. Some staff members may have developed health anxiety, which I mentioned earlier, impacting on their general well-being, whether that's physical well-being or psychological well-being. While the individual is off sick, keep in touch with them. Think about developing buddying and workplace well-being champions so that there are people in the workplace that can support others. Is flexible working possible, at least in the short term? Next slide, please. So ideas to promote general well-being. Ensure managers are aware of the impact on mental health and physical health. Careful work planning, avoiding back-to-back meetings. Think about work times, work when people start work and when they finish. For multinationals, where you may well have an individual, say, based in Colombo or Kandy, having meetings in Europe, perhaps the States and the Far East, is challenging if they're trying to do that all on one day. They have early start times and perhaps working until quite late at night, 9, 10, 11, 12 o'clock at night. Could you go back a slide, please, Sami? Thank you. There's a danger of teams becoming zoomed out. Many people report having back-to-back Zoom meetings as being very tiring. For staff working from home, trust them to work despite not being as easily visible. Experience in the UK is that people who are working from home are actually as productive, if not more productive, than when they're in the office space. But remember also, there's a social element to work. It's not just about earning rupees. Keep that going and be creative. Effective strategies used in the UK and Singapore, where I've got a contact, they started having virtual tea breaks, where they have Teams meetings, where the team meets up for short non-work social chat. How's things going? Where work is not allowed to be discussed for maybe 10 minutes. They've also had short team quizzes. And a Singapore colleague has arranged trips to the local botanical gardens and had work and non-work meetings in those gardens, obviously socially distanced and abiding by the rules of the country. And that's been very helpful. It's helped with team building, team cohesion, and the mental health of those workers. Next slide, please. So thank you for listening. I'm more than happy to take questions in the chat box. I do need to go on to another meeting shortly, just to highlight that there are a number of links within the next few slides, which Asani can send to you, with some resources on mental health, on work toolkits, some support webinars, COVID age, and also a link to the Chartered Institute of Personnel Development, which you may find helpful. Thank you very much. Over to you,
Anne. Thank you, Anne. That was very informative. There was a little bit of a miss. Dr. Susie, the chamber needs to launch their web page, and I will hand it over to Amanda for that for a few minutes, and then we will start this session again with Professor McDonald. Amanda?
Thank you, Asani. So we will be launching our Health Watch page by the Ceylon Chamber of Commerce, and we had the privilege of Dr. Susie Pereira to launch this for us today. So it will not take 2 minutes. We will be sharing the event on screen. Over to you, Dr. Susie, to launch our Health Watch page. Thank you. Thank you very much. So you may access this page through our chamber website, which is the chamber.lk website. This will be a very comprehensive site where you will get all current updates on the situation. And thank you very much. Let me hand it over back to Asani. Thank you very much.
Thank you, Amanda. So since we are there's time limitation, so let's head back to the session. And next in line is Professor Ian McDonald. He's going to talk about the long-term effects. Some of us may not be aware of it, but he's going to talk about the long-term effects of COVID. So he is Professor Ian McDonald has received the Order of the British Empire by Her Majesty the Queen. So we are privileged to have him here. He leads the Healthy Working Life group in the University of Glasgow. He is the chair of the Academic Forum for Health and Work in the UK and the COVID-19 Occupational Health Support Group of the Society of Occupational Medicine. He trained initially as a physician, then in occupational medicine, and his clinical experience is vast and diverse both in UK and internationally. He is the past president of the Faculty of Occupational Medicine and founder and past president of the Union of European Medical Specialties section of Occupational Medicine. He developed the healthy working lives paradigm, which was adopted by the Scottish government, is a member of the Disability and Carers and Benefit Expert Advisory Group in Scotland, and is a Bevan Commissioner in Wales. Over to you, Professor McDonald.
Thank you, Asani, very much for that introduction, and thank you very much for inviting me to this really interesting seminar. Are you going to show my slides?
Want me to? Okay.
Yeah.
I
I'll go quite quickly.
Okay.
Okay, so I'm going to talk about the long-term health implications of COVID. Next slide, please.
Is it not being shared? Sorry, is it not being shared?
I can see it. I want the next slide.
The extent of the problem, does it show?
Yeah, that's it now. Yeah, okay. So in the UK, we've had about 120, it's nearly 130,000 deaths, which is much more than Sri Lanka. Deaths are about 0.5% to 1% of all cases of infection, and therefore there's probably been about 12 million cases in the UK. Many of these are subclinical because young people will have had the infection but not necessarily been ill. Long COVID is defined as symptoms occurring for over 12 weeks, 12 weeks after the initial infection. And it is estimated to be at least 10% of all cases and possibly up to 20%. I think 20% is a rather high figure, but it's at least 10%. So potentially in the UK, we have currently potentially about 1 million cases of long COVID. That's 1 million of the workforce. Generally, they're working people who are still have symptoms and perhaps unable to work, and they're being referred increasingly to occupational health services. In Sri Lanka, I understand you've had 83,000 cases so far. You've had about 483 deaths. And so possibly you might end up with about 20,000 cases on the basis of the number of people you've been infected in Sri Lanka. But these are people. So this is the long COVID is what I'm going to talk about. Next slide, please. So this is a typical example. This was a patient of mine who's referred to me for advice about, in terms of a return to, in terms of her fitness. She'd been very fit and active. She liked going uphill walking, very active woman, and got COVID in March 2020, was in intensive care and ventilated for 3 weeks and had a further 2 weeks of rehabilitation afterwards. Extremely fatigued, vocal cord paralysis, breathless, lung scarring, can walk 200 meters with a stick in 15 minutes. She's had physiotherapy, mental health support, occupational therapy, speech therapy. Her house has had to be adapted so she can live downstairs. When I reviewed her in January, she was attending hospital and she can walk 400 meters and she's unfit for work. So that is the kind of effect COVID can have. Next slide. Next slide, Daseni, please.
I'm sorry, it doesn't seem to be sharing.
It's just slow. It's coming.
On full screen, it doesn't seem to be sharing. So I'll just extend the screen.
Okay. This is another case study, quick case study. 48-year-old man, very fit, used to do martial arts, regards himself as a tough man. His partner returned from Wuhan. Can people see the slides?
I'm sorry, there's an issue. Can you see the slides now?
I can't, but I can talk to it.
Okay.
So this is I can't see the slides.
Yeah, let me reshare it. Sorry for the technical issues.
All right. Okay, that's fine. So he became unwell in December. He was advised to see his general practitioner and didn't because he's a man. He could shake off his chest infection. In January 2020, he was breathless in exercise and had chest discomfort. He was still working. He saw his general practitioner eventually in February. He was referred for investigation. He had found to have lung scarring and myocardial damage. This is a healthy and fit man. He's got a reduced exercise tolerance. Spoken to him recently, he's still working, but he estimates his exercise tolerance is about 40% of what it used to be. And of course, he's not attending clinics because he doesn't think he needs to. So this is two examples of quite severe effect of long COVID. Next slide, please. So COVID can cause lots of symptoms, and this is an American study looking at acute COVID, where the kind of symptoms people have, mainly fatigue being the most important, breathlessness, joint pains, chest pain, cough, loss of sense of smell and taste is common, but many symptoms. And the post-COVID on the right-hand side here, you can see the kind of symptoms and long-term follow-up where people are still suffering from fatigue. Fatigue is the major and the worst problem after this illness. They're still breathless. They can have joint pains, chest pains, and the symptoms fluctuate. They come and go. So they can have periods where they feel quite well, and then they have a recurrence of symptoms. So it can be very disruptive, and also mental health problems occurring in a lot of these individuals because they've been fit, they've been working, and many of them are professional, and suddenly they're wiped out by this virus and struggling to get back to work. Next slide, please. So this is a slide. This is a slide which has been put together by a colleague, Dr. Claire Rayner, who is an occupational physician who had to be ill health retired because of long COVID. And it just illustrates how widespread the effects of this virus can be and the kind of symptoms that can occur. Well, not what we would expect with a flu or another similar viral illness, but much wider impact. In some reports, it's been shown that people with COVID infection, long COVID, you can have a 10% reduction in renal function. So it's a multi-system disease. Next slide. This slide is a bit more medical for the medical people who want to look at this. The range of symptoms which have been reported in post-COVID syndrome. So this is a new condition. It's multi-system disease. It's probably primarily a disease of blood vessels, affecting the lining of blood vessels. That's why it can affect different organs. Many people lack a diagnosis of COVID-19. They may not have been recognized as having COVID-19. They may not have been in hospital. They may not have attended their doctor and suddenly develop these symptoms. It's a new syndrome. It wasn't recognized initially. Often they've had inadequate clinical care because clinical care, as you know, is often by specialty, chest or cardiac or whatever. There's a lack of good rehabilitation facilities in terms of rehabilitation for work in this country as in many others. And so what's happening to them is they're ending up being referred to occupational health, where occupational health exists in terms of fitness to work. So there's been a slow response to the dealing with these individuals properly. In addition, there's a lot of cognitive effect. So memory loss, headaches, dizziness, neuralgia, and musculoskeletal symptoms. So, if you're a pilot or a train driver or a bus driver, there's many occupations are affected. And indeed, if you're a physician or an engineer, coming back to work with these kind of symptoms, the prognosis is of improvement. Next slide, please. So the COVID activity rehabilitation program has to cover issues about fatigue. It has to cover the respiratory function I talked about. It has to cover the cognitive issues. It has to cover cognitive impairment. It has to deal with sleep disturbance. It has to deal with mental health. So it has to be a multifaceted rehabilitation program. Next slide, please. Now, the burden for employers and occupational health services, that they're often young, skilled workers. They want to get back to work. They're feeling traumatized by this illness, and they've usually had inadequate rehabilitation. There's a cognitive effect and fatigue. They need careful assessment, and often they will not have had a holistic assessment to any great extent. Are there any clinical issues needing medical treatment? If so, they need to refer back to their general practitioner. But most need the rehabilitation of work. Work is good for people. The rehabilitation of work does help recovery, but getting people fit to start that process can be difficult. The process that's probably most effective in these circumstances, where you've got multiple, multifaceted condition, is that of biopsychosocial case management, which it's worth a lecture in its own right. So it's a holistic rehabilitation dealing with the mind and the body. A slow phased return to work or alternative work may be required. The prognosis is of improvement, but we don't know to what extent. And I advise people to use this, my 70% rules, that if someone thinks they can walk 100 yards, when they come back to work, don't let them walk more than 70. And then they don't tire themselves out and don't have a sort of seesaw rehabilitation. Next slide. So the long-term implication is a significant problem. It's poorly understood. It will have a significant impact on the workforce and economy. It's a big challenge for us. It's a challenge for health and safety. It's a challenge for employers. And we'll need innovative approaches to workplace rehabilitation. Next slide. So I've rushed through this, and my apologies for that, but I know time is tight in the programme. And this is an editorial which I and others wrote for the BMJ about return to work. And this is an issue for all doctors, not just occupational health, not just industry. It's an issue for society. So COVID-19 is something that's going to be with us for a long time. Many thanks for your attention. Thank you, Aseni, for managing these slides so well. And I have to leave for another meeting in 7 minutes' time, but I'll be very happy to respond to any questions.
Thank you. And what I thought was at the end of the session, we'll collate all the questions and maybe send it to you and Anne for if there are any questions towards you. So then we can respond, get it back onto the participants. Thank you so much, both of you, for sharing your knowledge and experience. Unfortunately, both professors are unable to stay with us because they have busy meetings with the MPs in UK. So they're busy people. We are very grateful that you participated and shared your knowledge, because long COVID is something that we haven't much discussed in our workplaces in Sri Lanka. So that is something we may have to look into in the future, when the disease spreads among the community. So thank you very much.
It's been a pleasure. Thank you very much.
Thank you. So if we move on to the next panelist, that's Dr. Changa. He has a lot of experience in infectious disease, so he will talk about the much awaited vaccine. And, there are myths and facts about the vaccine. Then Dr. Changa will also tell us how to build our immunity. So a brief introduction about Dr. Changa is he's a doctor of medicine, specializing in infectious disease and internal medicine and tropical medicine. He obtained his American Board Internal Medicine certification and was inducted as a fellow in the Academy of Medicine in Singapore. Changa's professional career has spanned in many countries. He has collaborated with the World Health Organization, US Center for Disease Control, European Center for Disease Control, and the Singapore Communicable Disease Center. He is well experienced in outbreak management, public health policy planning and implementation, and disaster preparedness and management. He has advised the COVID-19 task force in Sri Lanka and also advised local and international organizations on COVID-19 related activities. Over to you, Changa.
Thank you very much, Aseni. It's a pleasure to connect with you again. And I'll just wait for the screen to come up. Now, the first
Yes.
slide is going to look a little bit, it's going to look a little busy, but I want people to focus just on the red line. You can ignore the other lines on the graph when it does come up.
Hold on.
And this has to do with the, that's okay. I'll keep talking until it comes up. So this has to do with the time course of COVID-19, and why that's important is that when it comes to workplace, being away from work, when can you return to work, for all of those related questions, we have to understand the time course of the illness. Now, again, it's a busy slide, but just focus on the red line. Uh, on the top section, it's a time course for mild COVID. So mild COVID is something where you may not even have to be hospitalized for. You will see a black arrow, a vertical arrow with the arrowhead pointing down. That's the onset of symptoms. And you will see in mild COVID that the red line, which shows viral shedding, that is the virus leaving the affected person's body and spreading to others, actually starts before the onset of symptoms by about 2.5 days. And then it goes on to about 8 days of symptoms and stops. I think someone has their mic on. If admin can just turn that off, that'll be great. So a total of about 2 days before the onset of symptoms on to about 8 days. So that's where the 10 days of infectivity comes from. So it's important for us to understand that. Now, the picture at the bottom half of the slide is severe COVID. Now, if you look at the same red line, you will see that the shedding, in other words, the virus exiting the ill person's body and potentially infecting others, actually goes a lot longer than 8 days. It can go up to about 20 or 21 days if you project that red line forward. So that's an important difference between mild COVID, where the viral shedding is from 2 days before the onset of symptoms to about 8 days after symptoms. And severe COVID, where you've been in hospital or if you have a weak immune system, the viral shedding or the time that you should be away, isolated or in quarantine is a lot longer, up to 20 or 21 days. The last thing I mentioned about this slide before going to the next one is that you will see that you can be contagious before you start having any symptoms, fever, cough, what have you. So, which is why it's very, very important. I think Dr. Susie touched on this as well. Is to maintain your safe practices, your masks, your hand hygiene, and your safe distancing. Next slide, please, Aseni. So the next slide, I'm not going to belabor the point. This has to do with clinical symptoms. We are all, even as lay people, are aware of the symptoms. The white box at the left is before you start symptoms. Now, most people will only encounter stage 1, which is the fever, cough, diarrhea, headache, etc. But the stage 1 may be mild, or the stage 1 may be severe symptoms. People may actually feel very, very sick, but most of them recover without complications, without going to stage 2 and stage 3. Now, some patients, a minority of patients with severe COVID, will have an exaggerated inflammatory response, which causes damage to the heart, lungs, and vascular system. And those are the patients that will go to stage 2 with a lot of shortness of breath, low oxygen, heart shock and system shock, and problems with blood clotting, etc. But just this quick slide to show you that most people will only deal with stage 1 and recover, even though the symptoms may be appearing as severe. The majority of people do not go to the more critical stages. Next slide, please. Now, this slide hopefully will unlock a great mystery for everyone. We all recall SARS, the original SARS, the first innings, if you will, that happened in 2003. And it was there for many months. And then it's almost like it fell off the face of the earth. It just disappeared. And here's perhaps at least one reason why that was so. So the bottom part of the picture is the SARS back in 2003. Just look at the downward arrow, symptom onset. That's when the clock starts at day 0. And when you go to day 1, day 2, sometime between day 3 and 4, that's when um, viral shedding begins. So in SARS 2003, the sequence is a person gets symptoms first, then after about 3 or 4 days, that's when the person becomes very contagious to others. So even a child will tell us, wow, if you isolate this person at the onset of symptoms, you stand a very good chance of preventing spread of the virus to others. And that's exactly what the world's response was. Now go to the top half of the picture. Unfortunately, what we are dealing with SARS coronavirus 2 or COVID-19 is a bit unfair, isn't it? If you look at the symptom onset arrow, the viral shedding, as we discussed before, starts about 2.5 days before the onset of symptoms. So we can't go around isolating people who may have COVID in 2 days because we don't know who they are. Now, why I'm mentioning this in a workplace forum is it is very tempting to relax our practices, to take off that face mask, to forget about how important ventilation is, and go back to our tiny cubicles that are not very well ventilated. And I know Louise will touch on these aspects as well. So uh, because of what's demonstrated in the top graph, viral shedding starts before the onset of symptoms, which makes pre-symptomatic containment almost an impossibility, um, which is exactly the reason why we should all be setting an example and wearing our face masks properly to cover both our nose and our mouth, and taking these health measures seriously. Next slide, please. So here, with the vaccine, one of the tasks Asani charged me with was to really get to the meat of things with the vaccine. And thank you, Asani, for sending these questions in. I'm going to quickly go through these. Some of the questions that we have heard on the ground is, can I still transmit COVID-19 after vaccination? Thank you, Dr. Susie. You answered this question. Um, yes, you could transmit COVID-19 to someone else, even if you are vaccinated. The strong point of the vaccine is not preventing spread. The strong point of the vaccine is preventing severe COVID and preventing COVID deaths. I will repeat this a few times throughout my session so that we really understand that the vaccine is geared not necessarily to stop people from having COVID, but if I were to get COVID, my chances of ending up in hospital or my chances of dying from COVID would be greatly reduced. Next question is, does the vaccine stop me from getting COVID? No, it doesn't. How effective is the COVID vaccine? This is a great question. We all rattle off percentages. Oh, this vaccine is 85% effective. This vaccine is only 60% effective. But what are we referring to when we mention these percentages? So it's very easy. If anyone is curious, all you have to do is pull up any clinical trial for the vaccine and just look under the methods section. And the keyword you're looking for is primary endpoint. Okay, that's what the vaccine will be measured against. So in most of these vaccines, the primary endpoint is proven COVID or symptomatic COVID. And as secondary endpoints, you will have things like preventing hospitalization, preventing severe COVID, and preventing death. So when we talk of vaccine efficacy percentages, we must be clear in our minds. Are we talking about how good a vaccine is in preventing death, how good a vaccine is in preventing hospitalization, how good a vaccine is in preventing transmission, or how good is a vaccine in preventing getting COVID in the first place? I will go to that in my next slide a bit deeper, but let's go down these questions. Is the COVID vaccine safe long term? We hope so, but to answer that question, you need long-term data. So we will have to just be patient and be diligent about recording side effects and adverse events, and have a global registry almost of all vaccine recipients, and we have to follow up what happens to those in the registry over 2 years, 5 years, 10 years, 20 years, and so on. Who can take the COVID vaccine? Um, People who are excluded from the COVID vaccine are very, very limited. What I suggest people do is you can find this information on the internet. Whichever vaccine is being offered, so for instance, the AstraZeneca vaccine, you can find out the actual ingredients of the vaccine and see if you're allergic to any of the substances in the list of ingredients. A lot of people have asked me, well, I have hay fever, I have asthma, or I have food allergies, or I have an antibiotic allergy. Could I take the COVID vaccine? And the answer is yes. These aforementioned allergies are not reasons to exclude from taking the COVID vaccine. However, if you have very, very serious allergic reactions called anaphylaxis, where your throat can swell up, your lips can swell up to one substance, you may have a slightly higher chance of having anaphylaxis to another substance, in which case, what we recommend is when you take the COVID vaccine, please be under supervised medical care for about 20 or 30 minutes. Usually these bad reactions, if they're going to happen in the first 15 to 20 minutes. So that's the rationale for that period of observation that we use. Um, is the vaccine safe on people with comorbidities, so people with concurrent illnesses like diabetes, heart disease? Well, I propose that it is exactly those people who stand a higher chance of getting severe disease, hospitalizations, or deaths with COVID. So the vaccine should ideally be geared to those very patients. What are the side effects of the COVID vaccine? Generally, we'll be dealing with some aches and pains and fevers, usually in the first day or the first 2 days. You may have some fatigue. It is unusual to have major side effects beyond that. Of course, when you administer millions of doses, there are rare side effects like visual disturbances and neurologic issues that have come up, but these are very, very rare. So what I encourage people to do is when they are faced with a decision, we must look at four aspects. If you take the case of a vaccine or a medication, uh, what are the pros and cons of taking the vaccine? And what are the pros and cons of not taking the vaccine? So these are four things that people should consider. And that will help us answer the questions based on our individual risks and allergies and so on. How long will the COVID vaccine side effects last? Again, just like the previous question, we have to wait and see whether there are any long-term side effects, if at all. But most commonly, what we have seen is that the general side effects of aches and pains and feeling feverish, they usually last a day or two at most. Do I have to wear a mask after the COVID vaccine? I'm sure everyone in this forum will answer yes, because it does not, the vaccine is not geared to prevent transmission. Although some vaccines have shown good promise in this area, that is not the forte of the vaccine. What if I don't get the second COVID shot? Well, no harm will come to you, but you will lose out on reaping the maximal benefits of the two sequence injection. Even one injection can certainly offer some protection, and I'll show you some of this information in the next slide. But if you miss out on the second dose, then you lose out on a good opportunity to reap maximal benefit. Do antibiotics or other medicines affect the COVID vaccine? Not really, but there's something I want to mention because there's a common recommendation that goes around. Well, just take Panadol every 6 hours on the day before, the day of, and the day after the vaccine. Actually, my recommendation is not to do so. The fever response that you get from the vaccine is actually a test drive of your immune system. So it's an immune stimulation that happens. Now, we know from other vaccines, like the chickenpox vaccine that we give children, children who take fever reducing medicines may not have a robust response to the chickenpox vaccine, for example. So extrapolating from that data, if anyone were to ask me, I would say, look, if the pain is bearable, if the fever is not that bad, don't take any medicines to modulate your response. And this ties into our next question. If I get fever after the vaccine, does it mean I have a better immunity? I wouldn't say better. I would just say that having fever, body aches after the vaccine is an indication that your immune system is being stimulated. You may have a good immune response without having any symptoms, or you may have these symptoms and perhaps your immune response may not be as durable. Only time will tell. Let's go on to the next slide. And in the next slide, There are several vaccines that are commonly used. What I have highlighted is the one that the main vaccine that we are currently using now, which is the AstraZeneca vaccine. It uses another virus, not COVID. It uses another virus called an adenovirus to convey immunity, to stimulate the recipient's immune system. And I have some numbers on that fourth column there, or the fifth column. It's about 70% good at preventing symptomatic COVID. Um, but it's the other number that's quite valuable, 94% effective at reducing hospitalizations. And in the last column, I have mentioned where the data is available, whether it's effective against the UK strain, the South African strain, and also now we have to deal with the Brazilian strain as well. So the B117 is the UK strain. So the strength of these vaccines are actually in preventing hospitalizations, severe disease, and death. Next slide, please. So what we have here, I'm going to quickly whiz through this. We take vaccines to boost our immunity to fight off an illness. Well, why not supplement that, or why not give priority to boosting your own immune system at home? This is DIY for your immune system. In the interest of time, I'm going to just hit the main subjects. Adequate sleep, good quality sleep is essential for good immune function. Adequate hydration. If your tank is half empty, your immune system will not work. Your immune system is made up not only of your blood circulation, but of your lymphatic circulation. So what I encourage even my children to do is, when you pass urine, if your urine is yellow or concentrated, you haven't had enough water. So hydration is very, very key. Movement is key. Sitting is the new smoking. I love this term. Just like back in the 30s and 40s, we didn't know that cigarette smoking was harmful. The true harm of sitting and not moving will be apparent in time to come. So please, get up and move around, walk. Any option to not be motorized from point A to point B, please take that. Sunlight provides us with an opportunity to make vitamin D3, which is essential for immune function, especially against viruses. And getting a good hour of sunlight is much better than popping a pill. However, if your daily routine does not allow you to get sunlight to make your own vitamin D3, then supplementing may be an option. The fifth point, nutritious, wholesome food. It is apparent. Please adhere to this now more than ever. And then avoid toxins, whether it's in the form of fizzy drinks, cigarettes, processed foods, excess alcohol, or what have you. Stress management, just like Professor Ann alluded to before. When you have high levels of stress, it will directly affect the function of your immune system. And being connected. Now more than ever, when we are asked to distance ourselves and do everything on Zoom and Teams, please take up a project that you've liked to do. Help someone less fortunate. Get connected with your friends and cousins and families that you haven't been in touch with for some time. That sense of well-being is essential for good immune function. Next slide, please. And here, to finish off my part of the presentation, facts or myths. If someone in my workplace has coronavirus, does the whole workplace have to get PCR test done? The answer is no. Remember that PCR test is a diagnostic test. It is not a medicine. It is not a vaccine. PCR does not prevent people from getting COVID. PCR is a tool that we use for workplace health purposes. You can do any amount of PCRs. You can do PCRs 3 times a day and still come down with COVID, as we saw in the US White House with the previous administration. PCRs were done extremely frequently, but because of lack of other measures like hand hygiene, masks wearing, and distancing, almost everyone came down with COVID-19. Inhaling steam and drinking hot water kills coronavirus. Both of these are good for your immune system in different ways. Both of these are good for relieving symptoms. If my sinuses are congested, this is exactly what I do, but it does not kill coronavirus for the simple reason that to kill coronavirus, you have to maintain a 60°C temperature for at least 30 minutes or a 70°C temperature for at least 10 minutes. And you can't achieve these temperatures inside the human body in the soft tissues of your palate. If you try to do that, you will end up with very serious third-degree internal burns. So this is a myth that has been circulating. These are 4,000-year practices with tremendous health benefits, which I myself adhere to, but it does not kill coronavirus. The next point is there is absolutely no benefit in getting vaccinated. We've seen this message go on WhatsApp where questions are being asked. Well, if I get vaccinated, could I stop wearing a mask? If I get vaccinated, will bars and restaurants open? I think we've all seen that. And it's very disappointing because it just skims over one issue of preventing death, and it does not touch on the other issue of preventing hospitalizations at all. What the vaccine does best is that if people get COVID-19, they will be well enough to be managed at home without flooding the hospitals. If our health systems get overwhelmed, then all the other illnesses such as heart attack, strokes, sepsis, blood poisoning, kidney disease, cancer, etc., does not get treated, and people will die of those. So the next point is if you can hold your breath for 10 seconds, you don't have COVID, false. Drinking more alcohol or smoking excessively will prevent a person from being infected with coronavirus, false. I don't need to go into that. And people with certain blood types are protected from coronavirus. That's also false. There are certain immune nuances that determines who has mild disease and who has severe disease, but we are nowhere close to understanding what those are. And that brings us to the end of my part of the talk. Thank you so much.
Thank you very much, Changa, for busting all the myths and stating all the facts, especially of the vaccine and steam inhalation and those things, because some people have actually encountered burns because of inappropriate steam inhalation. Thank you very much for that. And next we move on to, I think time is, we are pressed for time. We might just go over a few minutes. So Louise, it's all yours. So if I introduce Louise, Miss Louise Bird leads the industrial hygiene program for GSK in Asia and Pacific region. She has worked as an occupational hygienist for over 10 years in pharmaceutical, mining, and chemical manufacturing industries. Her main interest lays in potent chemical exposure management and development of engineering containment strategies. So Louise will tell us about the important aspects of risk reduction regarding COVID. Over to you, Louise.
Okay, thank you so much. I'll just make sure you can see my screen when it comes through. You can see it now?
Loading.
Loading.
Yes.
Okay.
Okay, Louise, we can see.
Okay, great. All right, well, thank you again for inviting me to speak here today. I'll try and be as quick as possible, appreciating the time delay that we have. But so today I'll be taking you through strategies to reduce the risk of COVID-19 in the workplace and what control measures you can implement to minimise the risk. So I'll just touch on the modes of transmission, what we need to consider as part of a risk assessment, and implementing control strategies both for containing at the source as well as minimising the spread. So in order to determine the most suitable control measures, we need to understand the modes of transmission. Current guidelines determine transmission occurs primarily between through direct contact, indirect contact. Sorry, I'm not sure what just happened with the screen. Another user took control of the screen. Take control.
Do you want me to control?
I can control it. That's fine.
Okay.
Yeah. Sorry, which... Oh, it's sharing your screen. Okay, all right, you can share. That's no problem. I don't mind that. Yeah, sorry, I thought my screen was sharing. You're on mute.
Oh, it's your screen, Louise. It's not mine.
Okay. Okay, it says on mine it's yours, but that's fine. I'll just go back to it. All right, so you can see again. Okay, so current guidelines determine transmission occurs primarily between people through direct, indirect contact with infectious airborne transmission, and mostly through droplets. But there is more and more evidence supporting aerosol transmission coming to the forefront, as well as surface contamination. So in our respective workplace, we need to control the risk from all of those modes and act accordingly. So to effectively control the risk, workplaces should address the hazard in the same manner as you would any other risk, and that's by applying a risk management approach. So this involves conducting a detailed risk assessment in accordance with standard risk management processes. So identifying all activities or situations where people may be in contact with COVID-19 from each other or from a surface, assessing the level of risk that people in these activities or situations may contact and spread the virus. The level of risk associated with exposure to the virus will not be the same for all businesses, and it will depend on different range of factors, so business size, workplace demographics, as well as the nature of the workplace. So is it a factory, an office, a construction site? Things to consider when you're looking into this assessment. So is there frequent verbal communication? So is it a call center, for instance, where people are talking a lot? Is the work quite physical? So people will have higher expiration of breath. Do work tasks require workers to be in quite close proximity for the work to be carried out safely, so then cannot maintain any sort of social distancing? And is there shift work crossover? So is a workstation being used by two different people in the same day, for instance? So we need to determine what control measures are reasonably practical to eliminate or minimise the risks of exposure in each of these circumstances. So in order to control effectively, we can use the hierarchy of controls to guide our choices. So starting with elimination, it is critical that we stop people from entering the workplace with COVID-19 in the first instance. So ensuring workers are well educated on symptoms and what to do in the event of those symptoms occurring, as in do not come to work if you have these symptoms. We need to be able to support workers with access to testing and ensure there are clear procedures in place in the event of an occurrence. Additionally, screening workers on arrival at the workplace, so temperature checks, symptom checking, and clear requirements if these people have come into contact with a positive case, say at home or through other means. Substitution, obviously we cannot substitute the hazard, unfortunately, in this instance. Engineering control, so through ventilation and physical barriers, which we'll touch on a bit in a moment. And administrative controls, so work procedures, staggered work schedules, hygiene practices, and the like, as well as PPE, so through the use of respirators where deemed necessary, as well as the use of face masks and gloves. So the best way to go about this would be to develop a control plan that involves layered controls from each component of the hierarchy that's going to provide adequate risk minimization. So controlling at the source, so breaking it into controlling source and controlling spread. So if we look directly at the source, often in our workplace, we can control our workforce being separated from a hazard, but obviously with COVID, our workforce can be the carriers of the hazard, and we therefore must control the source by controlling exposure to each other. So to do that, we can try and limit the number of people in the environment. So those that can work at home should, or can we have a rotation policy in place with only a smaller number of workers at site at any one time? Implementing physical distancing, so when people are attending the workplace, they're able to maintain a social distance, putting physical partitions in place, modifying workflows, so processes and layouts so that work tasks are carried out in a way that minimises interaction between people. implementing hygiene practices, so developing infection control policies, so routine hand washing, access to hand sanitizer, and face masks. So the use of face masks, such as surgical masks or cloth masks, to prevent the spread from workers to others. Where workers cannot be physically distanced, though, you might need to consider high levels of PPE. So to touch on masks generally, there is quite a lot of information about masks floating around. And I guess, you know, we really need to understand the difference between the options available and what their purpose is. So a surgical mask, that protects the environment from the person wearing the mask. So this mask will capture large droplets being expelled from the wearer's mouth when they speak or cough or whatnot. They're not personal protective equipment. They will not protect the wearer from exposure to other people. But the idea is that if everyone wears one, it will minimize the spread overall. So comparing to a disposable respirator, such as an N95, P2, K95, these are all different certified respirators by different regulatory bodies around the world that classify the different classes based on the amount of particle penetration that can enter the mask. So tested, certified. Do have to be mindful, though, particularly at this time, of a lot of fakes floating around. There are websites available where you can actually check, say if the respirator says N95 or K95, you can go to the NIOSH website and check if it's actually approved. There's also a website for the Chinese certification of K95. So a respirator of this type will protect the wearer and the environment from airborne exposure. However, this is only the case if the respirator does not have an exhalation valve. So an exhalation valve allows exhaled material from the wearer to enter and contaminate the environment. So this second one in the respirator masks here. So whilst they will protect the wearer, they will not protect the person sitting next to them. So they aren't suitable as part of a COVID control strategy. So moving on to control of spread. So two key areas here, enhanced cleaning and disinfection. Definitely don't have time to go through that, but I have added some links at the back for people to take a look at later. And then providing adequate ventilation and air filtration, which I'll focus on. So adequate ventilation and air filtration can reduce the airborne concentration of COVID-19 and the risk of transmission in indoor air spaces. Ventilation can either be natural or mechanical, depending on the setting. So increasing ventilation rates can effectively reduce the risk of long-range airborne transmission, though it will do little in preventing the droplet-borne transmission of close contact, hence why we're looking at spread versus, contain of source. So a higher ventilation rate can dilute the contaminated air inside the space more rapidly and decrease the risk of spread and cross-infection. Compared with mechanical ventilation, natural ventilation can provide a much higher ventilation rate. So if your workplace is suitable for natural ventilation, then this is a really good cost-effective option for you to use. For mechanical ventilation, you need to ensure systems are not recirculating air within the building, and air changes per hour is at a sufficient level to reduce the buildup of contaminants. So we can see in this graph here, produced through research by the American Industrial Hygiene Association, increasing air changes to over 12 air changes per hour can reduce the relative risk by 99.9%, which is very high. But, natural ventilation, you can be looking up to 70 air changes per hour if that's a possibility. Having a lot of windows open effectively. So where air cannot be 100% exhausted, so you have some level of recirculation, you need to have a system of filtration of that air, and ideally through a HEPA filter or another form of higher capability filtration integrated into your system. Other filtration methods that are touted, such as the UVC radiation, they're not well-supported control mechanisms for COVID-19, and it's recommended that you stick with supported methods, such as HEPA filters. So other factors that are important when we're talking about ventilation, so flow direction. Flow direction controls the transport of contaminants from different areas in a workplace, such as different rooms. So you need to ensure that this is properly controlled to ensure that airflow direction is from clean zone to dirty zones. And this is great importance to ensure that virus-laden aerosols are not being transmitted between rooms. So, for example, a restroom area should not flow into adjacent workrooms where people are spending their time working, and your restroom should also be 100% exhausted outside. Airflow pattern consideration will ensure air does not flow over one person into the direction of another person. So downward airflow should be used to ensure this is the case. On this point, using a personal desk or pedestal fan should also not be used, as that's what's going to happen. The airflow pattern will flow from one person straight over to another. So I guess a key point here is that it's important to understand ventilation system of your workplace and to work with your maintenance or engineering teams to ensure you have the system configured to work at its most optimum to reduce the viral load in the environment. So key things for you to consider in your workplace. Determine if increasing natural ventilation is possible and safe, and considering the outdoor air quality as well, so air pollution, temperature, humidity of the environment. Ensure that any HVAC system is maintained and operating in accordance with manufacturing instructions, particularly in relation to cleaning and changing of filters. Be aware that HVAC systems only filter the air when the fan is running. So businesses should run the system for longer times or continuously if possible, even if the air does not need to be heated or cooled. So for instance, if you're a 9 to 5 building, you want to be running that for longer than that time to ensure that that airflow from that period has been fully cycled through. Ensure that where recirculated, that the air is filtered by a HEPA filter if possible. And ensure that exhaust fans in restrooms are fully functional, operated continuously when the building is occupied. It's important to note that when increasing outdoor air delivery through a ventilation system, maintenance need to take precautions to avoid over-exceeding the system's design as well. So that's why it's quite important to make sure that's reviewed, and if need be, engage a ventilation engineer or an occupational hygienist. So just to close out, ensure it's a well-ventilated environment that you're working in, but this will only work if you also include all the other control mechanisms we have, so physical distancing, hand hygiene, PPE. It's really important that communication and training of staff is carried out, that they know what they're doing and why they're doing it. You also need to ensure that you're evaluating the effectiveness of the control measures you've put in place to identify any gaps or issues that have not been adequately installed with in the first place. And so I've just put a couple of resources there. So that one on cleaning that I mentioned, as well as the American Industrial Hygiene Association Resource Centre, where there's heaps of stuff, particularly on ventilation. Yeah, that's it, I think. Yeah.
Thank you, Louise. That was very informative. And I think we now know that ventilation is very important to ensuring workplace safety, the employee safety. So I think we all need to look into our workplaces, especially if we are working in enclosed environments, because definitely. That is one way that the COVID-19 can spread. So sometimes we focus on the surfaces more, but we neglect the airborne and the ventilation systems.
Yeah.
So we are running over time. Sorry about it, Artha, and sorry for the participants. I hope you're okay with it. It's quite interesting now. Finally, somebody from the same predicament as you all are, trying to manage keep their employees safe with minimal disruption to business continuity. So Artha has faced all the challenges. So he's here to talk. If I introduce Arthur a little bit more, he's an occupational health and safety professional with both local and international experience. He's currently the Associate Director for Environmental Health and Safety and Risk Management at ANSWER, responsible for Asia and Pacific region. This covers actually operations in Sri Lanka, Malaysia, Thailand, Vietnam, China, looking after over 10,000 employees. So he specifically his training, experience, exposure in business continuity planning and crisis management and role as a part of ANSWER global risk management function made him an integral part of the team that put together COVID-19 guidelines and control measures for all ANSWER global manufacturing facilities. So Arthur has a lot of experience, not only in the practical aspects, but also developing all the guidelines for the global ANSWER global. So over to you, Arthur.
Thanks, Aseni, and good afternoon, everyone, and thank you for sticking around. I know it's a bit late. I'll try to keep this fast and brief as much as possible, and any questions that come up afterwards, we will be more than willing to respond to later on. As you can see on the slide on screen, we're talking about COVID and what is known as what we call it the ultra marathon. It's been going for over a year now, and even though the vaccines are out there and there are some positive signs coming out, we know that it's still not over. So it could also become worse as well because people might be overconfident from taking the vaccine. So just to touch upon some of the things, sorry. Did I lose the screen?
Yes, you
Somebody
did.
else started sharing the screen, sorry.
You're back on.
All right, there we go. So as everybody in this webinar has talked about, we need to stick to the basics, and that's what we have been doing since day one. And that has worked for us pretty well considering the lay of the land. We have manufacturing facilities ranging from Brazil all the way to China and everything in between. So we actually got exposed to COVID as an organization quite early from a Chinese facility. And that also resulted in us getting some learnings ahead of time. And what we understood was, look, we need to have a license to operate, and this needs to be adopted across the board, irrespective of whether it's a manufacturing facility, an office, or a distribution center. With that in mind, we focused on 4 pillars, which everybody else has talked about, and I know that we practice on a regular basis in Sri Lanka as well, which is you do the employee screening properly, you wear masks, everybody wears masks, you have the social distancing either through physical barriers or through physical distancing, and you make sure that the sanitization practices are being maintained. We have found and learned that where there have been breakdowns of these 4 pillars, one or more, has resulted in internal spread. And that has been well documented. And some of the challenges or the benefits we've seen is places where we have seen risks popping up, we realize that where the controls have been very strongly enforced, the spread has not been significant or even actually beyond the case that tested positive. And that is where we talk about these 4 pillars and say the 4 pillars need to be mandatory across the organization, irrespective of what level in the organization you are. You need to stick to these 4 pillars. These 4 pillars need to be well communicated to employees, as both internal employees as well as contract workers and contractors who come for the site. And then it also needs to be audited for compliance. There is no point in having signage and policies that are not being verified for compliance. So what we did as an organization was we repurposed our quality audit teams. We repurposed most of them to do audits on COVID-19 compliance as well. And they generated reports on a regular basis on any non-compliances where we could take activities, actions necessary to rectify as well. And also our strategy has evolved. Like I said, ANSWER got into this probably from about January, February of last year, when the spread started moving out of China. And our response strategy at the beginning was more of prevention. We wanted to try to stop COVID-19 from entering our manufacturing facilities primarily. Officers, folks could work from home, but the real load of the workforce was in our manufacturing site. So we focused on prevention, making sure we build a wall of protection around. And then as um, the communities around our facilities and the localities where we were based started having larger numbers and higher outbreaks, we realized that it would come to a point where it's not if our sites could get impacted, it would be when. And to that purpose, we started shifting our strategy from being a prevention focused strategy. I mean, all those controls were still being maintained, but to a minimization strategy. It was called Cluster Buster. This was a global strategy that was put together. And the idea was we need to, because of the high risk and probability of there being cases coming into the site and because of the asymptomatic risks that exist, we wanted to make sure that we will not be a source of a cluster within ANSWER. And it was with that in mind that we had the Cluster Buster strategy forming up. In the interim, we would have external monitoring. We would keep an eye on where the cases are popping up, because in countries like Malaysia, where they have zonal isolation and movement control orders, in countries like Lithuania, where there are risks as well, we had to make sure that we knew exactly what was going on outside of our facilities. So the external monitoring was very critical. That actually led to a proactive response in some sites where we said, look, if you're coming from a high risk area, stay at home. Right? That was one of the first steps we did. The next step we did was we also created, I know we've heard of bio bubbles, but we also focused on what was like a geo bubble. If you are coming into work from an area which might be at risk, we would provide you with separate transport, bring you in, keep you isolated, you do your job, and you go back home. That was another strategy that we used. In addition to that, we provided zoning within the facilities as well to minimize interaction across the board, across departments. So they would eat at the canteen in staggered timings. The only issue that we had was transport. From March last year, for example, and Sri Lanka, we and ATL, our site in Sidhu, we have been running our buses with the recommended spacings that were set forth very early on in the day. I mean, that almost doubled our bus fleet, but we realized that that made sure that the controls that we put in place were not diluted. And that resulted in, we realized that our transport system was actually one of the lower risks that we had. So the zoning coupled with that made sure that there was a lot less interaction happening within the organization when people came into work. Testing, we realized that there was some mandatory guidance that came along, but we are not talking only about Sri Lanka. Our testing strategy had to be done on a global basis. And that made things a bit difficult because unlike in countries like Sri Lanka or the Asia Pacific region, Europe and the Americas, they're very particular about their medical privacy, getting people to be tested, and then even to the point of people getting temperature checks at entrances became a challenge. We had to get corporate legal involved in all this. So all of these challenges were there during the implementation of it. But we did come up with a global testing plan on frequency, how samplings were done using ISO standards for sample testing. So we had three different layers of testing or types of testing that was done. The random testing was done for surveillance purposes. We also did risk-based for assurance, where we had high density groups in certain work areas. If they could be working in an enclosed environment for a longer period of time, we would then increase their frequency and do it based on the risk of a spread occurring within that area. And then we would also do proactive testing for to get ahead of a cluster in the event that we had positive cases. We also talked about geo bubbles and bio bubbles a little bit as well. All of this was actually supported by our global crisis management and recovery plan, which we got ahead and got the team set up to do. Like I said earlier, we had some best practice sharing that happened. I remember back in February and March, we actually provided some documentation to the Ministry of Health at the time uh, from some of the guidance documents we had received from Malaysia on how industries are supposed to restart operations. And we're glad to see that those were some of the things that actually made it to the final documents that came out. And finally, one of the major things that we have continued to do to date is communication. We need to communicate with the employees on a regular basis, and that becomes such a challenge sometimes because there is so much misinformation that could go wrong. You heard Changa talk about myths and facts. We need to make sure that we understand that the communication is being done effectively, and the employees always see you as a true source of information and do not resort to spreading myths and rumors around the workplace as well. So openness and having that communication lines open were very critical for us as well. The contact tracing and case management part of it, again, Ansel has a slightly different approach to this. However, in Sri Lanka, this is the guideline that is available. This was released in December of last year. If you have not seen it, please take a look at it. And Asini, I think we'll be able to share the link or the document itself on the WSHA website once it's ready. So these are some of the guidance that has been provided on managing cases, how you are supposed to or how you are expected to handle COVID positive cases, and how you're supposed to deal with close contacts. A lot of folks have asked us many times, what do you do with your employees? What do you do with your close contacts? What is a close contact? Now, whilst we use as an organization, we use the evolving definition that the US CDC has for close contact. What you see on top of the screen is what is expected in Sri Lanka, and that is what it is available. And some of the documents that are expected to be collected during an exposure or post-exposure is available on screen. And I will, again, not going to spend too much time on this, but I'll share this for your reference as part of the reference pack. Anne talked a little bit about this earlier, but this is something that we have really as an organization, this is our next step. This is what we're focusing on right now, because like I said, we are in this for the long haul. And pandemic fatigue and the associated impacts of it in the workplace is very real. Some of you, all of you, uh, may have yourselves or may know of somebody who's experiencing some of these symptoms because a lot has changed in our lives. We have, in some cases, lost control of our work-life balance, and in other cases, we are working with reduced workforces. There's a lot of pressure to perform. There is financial pressure. Such a significant uncertainty out there that leads to very subtle issues. And one of the biggest things that we have in our part of the world, talking about mental health problems is not a common thing. And I'm assuming that most of the folks on this call are either at an executive or manager level. We do not really ask for help. We make sure that our people are looked after. Our associates in the shop floor, we make sure they are looked after because they are protected in that sense. But it's very rarely the leadership team, the managers, the supervisor, they really look after themselves. And that is why we as an organization have, over the last 3 weeks, it's not something that we've been doing for a while, over the last 3 weeks to a month, we've been really focusing on addressing the impact of pandemic fatigue in our management teams. One such step that we've set up is to make sure that managers, GMs, CEOs, these are the folks that are on call, right? They're on the edge because they don't know what will happen overnight. There could be cases breaking up and stuff like that. So they've designed, or we are in the process of defining leadership rosters for off days, for weekends, for holidays, because if your operation is running 24/7, you can't be on call 24/7. The other thing that takes up so much of our time is meetings. We spend so much time on COVID meetings. For at one point there was a meeting or two every day during some of the peaks that we've had in the organization. So we wanted to reduce the number of meetings that take place virtually. Almost nothing takes place physically now. Virtual meetings, because you're reducing the time spent in front of the computer. Cutting down the frequency if you can't eliminate it, and focusing only on essential participants. This is a webinar. We have 100 plus people, which is very good, but that's an info sharing session. But there are some times when there's one person talking, there's 20 people listening, and we realize that in some of those sessions, more emails come from the participants on other topics, so you realize that no one's paying attention to it. So why waste people's time? So focus on that a little bit as well. And the other one is sharing pre-reads. You don't have cold call meetings essentially. You need to provide the documentation ahead of time to refer to. You need to have an agenda, minimize the duration of meetings. We do not have any meetings that go above 1 hour anymore. It's been cut down. If you need a more longer meeting, I think it was Anne who talked about this as well, about organizations that are multinationals that work across the globe. Like I said, we work from all the way from Brazil to Melbourne, China, and hit everything in between. So we've actually established a golden zone for meetings, which covers the Americas as well as Asia Pacific, because that's kind of two ends of the pole, and make sure that we do not have meetings that fall into the evening of Asia Pacific, which is the morning in the US on Friday, and we don't have meetings early morning or in the morning hours of Monday for Asia Pacific, which is Sunday night for the US. And we've mapped out a time zone that works as well. And after that, the other one is primarily looking at a buddy system to allow leaders to ask for help and support. I know that everybody has to maintain this image of strength and solidarity for their teams, but that does not make you any less human. You are vulnerable, you will have impacts. So you need to be able to talk and ask for help if needed, and that needs to be facilitated within the organization as well. And finally, leaders must walk the talk. There's no point in saying, don't do this if you don't facilitate the ability, if you don't facilitate the environment that gives your teams the opportunity to act upon it. Right? So you need to give them the support and the tea parties that I think the virtual teas, for example, where you don't talk about work but just engage on a different level, creates that sort of environment. But just sending an email and saying, I don't want you to do this. I want you to take time off and spend time with the family, but then keep loading folks with work does not really help them deal with the situation either. So to quickly wrap up from this, the key takeaways is, don't forget the basics. We are still not at the end of this journey. We still have a bit of ways to go. The vaccine, again, could cause a situation where employees, after they get it, think they're invincible, and that could result in them taking unnecessary risks. So please make sure that the controls that you have established and you have maintained all these times is still being enforced, and explain to the employees why it is there. The myths and facts that Changa dealt with on vaccines, I think that's a very important thing to be shared with the employees on a regular basis to build their awareness. The other thing is, we don't know what's to come, right? We need to plan for the worst but hope for the best, because you need to be prepared, as we don't know what. There could be a new strain that makes things a bit difficult for us, so we need to plan for that. Pandemic fatigue, the last slide I talked about, is a real thing. Please think about it. Please, as leaders in your organizations, as managers, please look into this. Otherwise, it could cause irreparable damage to your organization and your workplace culture, and that's not something a vaccine can take away. We talked about managers and supervisors needing help. Focus your strategy primarily on being people-centric. Make sure you always communicate on a regular basis with your employees and each other. And finally, this is truly the key to success. Managing COVID or the related controls is not something that can be done by EHS, OHS, HNS teams. and HR alone. It needs to be done as a team because, for example, the site that I'm based out of in Sri Lanka, 36 acres, 3,000 plus employees. You can't have 2 or 3 people from HR and EHS trying to make sure that everybody is taken care of. Everybody needs to play their part and everybody needs to play the part of leaders, and that is what is important. Because at the end of the day, we are talking about workplace safety and COVID. Our responsibility is to make sure that everybody goes home safe at the end of every working day and they're kept safe. And that is everybody's responsibility. And that is what we all need to do together as a team. And that brings me to the end of my deck. Sorry, Arseni, I'm not sure if I ran over time, but over to you.
Thank you, Arthur. That was very useful. Yes, we have 25 minutes over time. I'm sure we'll run half an hour. But I need to listen to all the panelists speaking. I need to stress on the pandemic fatigue, which actually is a stressful factor in your body, which causes hormone, disruption in the hormone secretion, which can impair the physical health of a person. So if you're ill, or if you're physically fatigued, then there's a greater chance of contracting any other viral or any other disease. If you're weak, if your immunity is low, there's a chance of you contracting. So you have to ensure the mental health of the employees should be looked after. We cannot stress on that issue because it's not only the physical aspect, we also have to look into the mental health aspect, and if possible, identify the sick and the vulnerable in your workplaces and try to, at least keep them identified in case you need to provide some kind of a relief for them, you know who they are in advance. That is all from the panelists and us. I hope it was a very useful session to all of you. So like I said in the chat box, we will send you all the video recordings, the links, and the answers to the questions. But most of the questions were answered by Changa on the chat box itself. So if there's any questions, further questions, you can inquire through the WSHA website. And I need to thank Mr. Lankapriya Galevatta, the president of the Workplace Health and Safety Association as well, who has helped us in organizing this event. So WSHA is a non-profitable organization. Okay, is a non-profitable organization. So it is there to support the private sector in health and safety concerns. So please, if there's any concern, you can find us through that website. I think, and I also need to thank Jillian, Niroshini, Amanda, and the team at the Ceylon Chamber of Commerce for their tireless efforts in organizing the event and providing the platform. So thank you very much all. Let's adjourn the session. Thank you for all the panelists. It has been very informative. There are more questions coming on now. What we can do is we can respond to those through email, right? Okay, thank you all. All the best. Good afternoon.
Thanks, Arseni. Bye.